a medical oncologist and clinical investigator specializing in breast cancer. He's a professor of medicine at Harvard Medical School, an institute physician at Dana-Farber Cancer Institute and Brigham and Women Hospital. Dr. Harlot will talk about optimizing adjuvant therapy in genomics. Please, Dr.
Thank you
Harlot.
thank you very much for inviting me to speak today. I'm honored to be with you, and I'm especially grateful to Dr. Al-Sayed and Dr. Murshid for giving excellent talks, which really set the stage for the remarks I will share with you. For estrogen receptor positive breast cancer, I think it's really important to think about genomic testing in ways that Dr. Al-Sayed already mentioned, and I'll try and elaborate on them a little bit. First of all, I want to show you a picture of Dana-Farber. This is our clinical building here in Boston. My office is up on the top floor, but I don't have a very good view, and our clinics are on the middle floors here. I have no commercial conflicts of interest to report. So ER-positive breast cancer is a very heterogeneous disease, and as everybody knows, we characterize these tumors by grade, by the degree of estrogen receptor expression, by the degree of proliferation with things like the Ki-67 assay or a grade marker. And in general, these correlate very well with the recurrence score and other genomic assays. Low grade, strongly ER positive tumors tend to have low recurrence scores. Higher grade, lower levels of estrogen receptor or progesterone receptor expression tend to go along with lower proliferation measures and higher proliferation measures and higher recurrence scores. So we've been thinking about these kind of clusters of breast cancer for a long time, and we will often distinguish them as so-called luminal A, which are strongly ER positive, low grade, low risk genomics, and luminal B, which are high grade, lower estrogen receptor, higher risk scores on genomic assays. And the questions are, how do we operationalize those on a day-to-day basis in our clinics? So you've already heard about the TAILOR-X assay or study this morning. The important point here is that this was node-negative patients with intermediate recurrence scores of 11 to 25, randomized to endocrine therapy alone or chemotherapy and endocrine therapy. And as Dr. Al-Sayed already pointed out, there was absolutely no benefit for the addition of chemotherapy overall in this clinical trial, a very clean negative result. In the RxPonder study, which was fundamentally similar, this was node positive patients, so women who had 1, 2, or 3 positive lymph nodes, a recurrence score of 0 to 25, again, randomized to endocrine therapy alone or chemotherapy plus endocrine therapy. Overall, no significant benefit for adding chemotherapy, a 1% absolute difference, certainly not worthwhile for chemotherapy treatment. And the third major study here was the so-called MINDAC trial, which was looking at a different genomic signature, the MammaPrint assay. And it took patients who had a high or a low MammaPrint score. And those women were again randomized to chemotherapy or not. And what you can see up here, for instance, in the top panels, is that such patients got no benefit from the addition of chemotherapy, especially when the recurrence or the genomic assay risk was considered low. So we have multiple studies to suggest that low genomic risk cancers do not benefit from chemotherapy. And that's really important because the vast majority of estrogen receptor positive breast cancers have low risk scores. These are data from the United States, looking at 50,000 cases tested by the Genomic Health Oncotype assay. And what you can see is that 83% have a score that's either less than 11 or somewhere between 11 and 25 in the node negative population. So for 85% of women with newly diagnosed breast cancer, we can avoid chemotherapy. It's a very powerful finding. So the first lesson is that the vast majority of patients who have N0 or N1 ER-positive breast cancer won't benefit from chemotherapy. And as you've already heard nicely discussed by Dr. Al-Sayed, genomic assays readily assign patients into a treatment group. Okay, but what about the premenopausal women? And this is where I may have a little bit of a disagreement with Dr. Al-Sayed. because I think we are over treating these women with chemotherapy still. So as you heard, in the group of women who were less than age 50 in Taylor X, who had intermediate or higher end recurrence scores between 16 and 25, it looks like there's a benefit for chemotherapy. But the question is, how much of this is due to the ovarian suppression effects of chemotherapy, and how much of it is due to the idea that chemotherapy is actually poisoning the cancer cells? And if it's ovarian suppression, then obviously we can accomplish that without giving the chemo. And if it's cancer cells being killed by chemotherapy, then obviously we need to give the chemotherapy treatment. So which is the right answer? Well, you can make some predictions here. And one prediction would be that you would expect the results to vary as a function of the patient age if chemotherapy-induced menopause or amenorrhea is the contributor. So for instance, if the women were less than age 40 and the likelihood of going into menopause with chemotherapy is low, then you would predict that there is no benefit to chemo if you believe that the consequences of the chemotherapy treatment are all because of ovarian suppression. And by contrast, as the patient gets older, 41 to 45, and then 45 to 50, and the chance of going into menopause with chemo goes up, you would predict that you would see more benefit from chemotherapy in these older women. And finally, if you were age 50, if you were postmenopausal but younger than age 50, then you're already in menopause, and you would again predict that there would be no benefit for chemo, even if you're in your 40s, because you're already in menopause. So it turns out that's exactly what the data show. So if you look at the data here from the Taylor X trial, you'll see that if you're less than age 40, there's actually no benefit to chemotherapy. Whereas if you get 41 to 45 and then 45 to 50, the benefit of chemotherapy goes up. And finally, if you're over age 45, if you're less than age 45, but you're already in menopause, again, there's no benefit to chemotherapy. The only rationale that explains these data is the idea that chemotherapy is pushing women into menopause, not that it's actually killing off the cancer cells. Otherwise, these data make no sense. So my own guess is that nearly all the benefit of chemotherapy for women who have low-risk genomic signatures in ER-positive breast cancer is because of the ovarian suppression effects. Well, what about the RxPonder data? So here's the data for postmenopausal, absolutely no benefit. As you saw from Dr. Al-Sayed, there was an apparent benefit in the premenopausal women. So again, the question is, what accounts for this difference? Now, we don't have good data here yet in the same kind of analysis, but personally, I find it very difficult to imagine that a 45-year-old woman who has a low-risk genomic score all of a sudden gets benefit for chemotherapy when there is a 55-year-old woman who does not. And another complexity here is that if you look at the outcomes by the recurrence score range, you actually see big benefits for chemotherapy in the premenopausal women for both the low recurrence scores and for the intermediate recurrence scores. That, again, is a puzzling observation for me, because a lot of studies, as shown by our previous speaker, have already suggested that these very low recurrence scores simply do not benefit for chemotherapy. Again, I think the only explanation that really accounts for these data is the idea that ovarian suppression is the major contributor here to the benefit for chemotherapy in these patients. Is there a reason to imagine that ovarian suppression is as good as chemotherapy? Yes, there absolutely is. So our older colleagues in the audience will remember some of the older trials that looked at ovarian suppression versus chemotherapy. And what was interesting is that, in fact, in many of these studies, ovarian suppression had the same exact consequence as chemotherapy in younger women with ER-positive breast cancer. And in one of the most important studies, the so-called ZEBRA trial, ovarian suppression actually had the exact same benefit in ER-positive cancers in young women as did CMF chemotherapy. In a more modern era, we know from the SOFT trial that adding ovarian suppression to young women with ER-positive breast cancer is a very important intervention, especially in higher risk ER-positive tumors, with substantial gains in preventing breast cancer recurrence. Whether the patient got chemotherapy, it makes about a 5% difference if they did not get chemo, and about a 9% difference if they did get chemotherapy. So there's a lot of evidence to suggest that ovarian suppression can be an important addition to women who have premenopausal breast cancer. And my guess is that for women who have low-risk genomic signatures, the majority of the benefit that you see with chemotherapy comes from ovarian suppression. So my second big lesson here is that the numerical benefit of chemotherapy in younger women is most likely because of ovarian suppression effects. And so for a lot of these younger women, we are actually not giving chemotherapy, but we are in fact giving ovarian suppression. And hopefully we can talk about that in our Q&A in a few minutes. Finally, what about genomic testing and the role of different types of endocrine therapy? And again, we've just heard a very nice discussion from Dr. Murshid about extended therapy and endocrine therapy choices, and I'll try and show some genomic data that relates to those choices. These are data again from the Taylor-X study, just to make the point that in women getting endocrine therapy, the genomic test is a very strong prognostic marker. So if you have a patient with a score of 0 to 10, they have a better outcome getting endocrine therapy than if the score is 11 to 25, or if the score is greater than 25. With every incremental risk gain in the score, the outcome gets a little bit less good. But those data do not tell you whether or not the patient needs endocrine therapy or which kind of endocrine therapy. It's simply a prognostic marker along with tumor stage, nodal status, and tumor grade. One of the questions that's asked is, do luminal A cancers and luminal B cancers get the same benefit from endocrine therapy? This was a very nice study from Laura Vontveer looking at an old trial, the old Stockholm trial from the 1970s and 80s, where women with breast cancer were randomized to tamoxifen alone or no adjuvant endocrine therapy. And they then stratified the outcomes by the 70 gene signature, the MammaPrint assay. And what you can see on the right is that low risk or luminal A breast cancers have a better prognosis overall, but still benefit from endocrine therapy with tamoxifen. Luminal B signatures, shown here on the left, or high-risk MammaPrint, actually have a less good prognosis, but they still benefit substantially from the tamoxifen treatment. And if you look at the proportional risk reduction, it's actually the same for both groups. Though, in fact, the women who have luminal A or low risk cancers get numerically smaller benefit because they have a better overall prognosis than the women who have luminal B cancers, which actually get more absolute benefit. The key point here is that endocrine therapy works across the spectrum of genomic signatures in ER-positive breast cancer. And in fact, adverse genomic signatures probably get more benefit from endocrine therapy than lower risk, more favorable ones, because they are riskier at baseline. Now, there's been some interesting work recently to further refine this MammaPrint readout. Instead of just using low versus high, they've actually started classifying them as ultra low. And a small group of women with ER-positive breast cancers, it's about 10% of women who have these signatures, end up having extraordinarily good prognoses. In a couple of studies, they have nearly a 98% cancer-free survival through 15 years of follow-up, which is really quite remarkable. So increasingly, I think we're going to be looking at not just is it high or low for the MammaPrint, but is it ultra low? And similarly, these would be patients who have very low genomic health oncotype scores, probably that 0 to 10 population, where through a decade of follow-up, there's less than a 3 or 4% risk of cancer recurrence. And I think beginning to share that information with patients is going to become more and more common. I'm going to skip the next slide because I want to get to this discussion, which Dr. Murshid introduced, about the question of extended duration endocrine therapy. He showed you the data from NSABP B42, which showed that there was a small benefit for longer durations of anti-estrogen treatment with aromatase inhibitors after 5 years of therapy. And so the question is, could we begin to use genomic assays to figure out which patients need extended adjuvant endocrine treatment and which do not? And so there were two reports at the ASCO meeting earlier this month where they tried to tease out the data from NSABP-B42 to ask whether or not genomic signatures could identify patients to get extended endocrine therapy or only shorter durations. And the answer was no. We could not use genomic assays to figure out which patients benefited from extended endocrine treatment. These are the data from the MammaPrint analysis. If the patient had a MammaPrint high score, they still got some percentage of benefit from extended therapy with the aromatase inhibitor letrozole, as they did if the MammaPrint signature was low. There was still a 3 to 4% benefit for such treatment. And similarly, using a different genomic assay, the so-called breast cancer index or BCI test, there's a stratification to high or low. And in both groups, there was actually a benefit for extended adjuvant endocrine therapy. Admittedly, a small benefit, but the point is that the genomic test cannot tease out who needs extended therapy or not. So the third lesson here I wanted to share with you is that for ER-positive breast cancers and women receiving endocrine therapy, genomic signatures have an important prognostic role. And increasingly, I think we are interested especially in figuring out the very, very low risk patients, because wouldn't it be nice to be able to tell a patient, you have an extraordinarily good prognosis with endocrine therapy. You know, it's not just that you're in a good risk group, but really there's less than a couple of percentage points chance of ever hearing from this cancer again. That would be very gratifying. However, decisions about things like ovarian suppression, the use of an aromatase inhibitor versus tamoxifen, or the duration of endocrine therapy are based on traditional considerations of risk and not on these genomic signatures. So let me try and share with you my overview of how I think about ER-positive breast cancer and what kinds of treatments to escalate or de-escalate, as was said earlier in our session, for women with that treatment. This is a figure that I put into a New England Journal of Medicine review article that we published in December. It's online if anybody wants to look at it. I hope you will. And here's what the argument was. I sort of tried to make the point that you can classify patients into two axes. One axis on the y-axis is the biological risk of the cancer. How aggressive, how proliferative, how risky a genomic signature does the cancer have? And on the x-axis is the anatomic stage, stage 1, stage 2, and stage 3. For women who have low-risk tumors and low stage, we're using standard 5 years of adjuvant endocrine therapy, either tamoxifen or an aromatase inhibitor, as you prefer. As the patient's stage goes up, or as the patient's biological risk marker goes up, we are offering more intense endocrine therapy. So that means ovarian suppression if the patient is younger, and it means longer durations of therapy out to 8 or 10 years for higher risk cancers. It also means we push people a little more to get to an aromatase inhibitor, which has small benefits over tamoxifen. With chemotherapy on the right-hand side here, it's a similar discussion. For stage 1 tumors where there is a low risk by anatomy and a favorable prognosis by biological risk using those genomic signatures, there's really no role for chemotherapy. By contrast, for most women who have stage 3 breast cancers, we are still using chemotherapy. In between, for the limited stage 1 or 2 cancers, we're leaning very heavily on that Oncotype DX score, and we're thinking about chemotherapy for high signatures. And for the younger women with the low signatures, there's still a debate, though, as I said, much of that benefit, I think, is actually from ovarian suppression and not from chemotherapy. So I want to thank you very much for asking me to join you today. I hope that you are all safe and healthy. I look forward to a time when we can be traveling more to see one another at international conferences, and I look forward to our panel discussion, which begins now. Thank you very much.
Thank you so much, Prof. Burst, for kind of an overview about the data that we have with hormone and genomics and so on. You know that when it comes to hormone positive breast cancer and the adjuvant setting, I think we always rely on the anatomical, as you describe, as well as genomic, and really difficult to differentiate between both, and it should be complementary to use both. And I will start probably the first question, if Dr. Amin allow me. And that's probably for your last talk, as well as probably Dr. Sayed talk, which is regarding to the genomics and our exponder trials, which really give us more kind of an overview about how to deal with the hormone positive or not positive premenopausal, and it really drive the oncologist to prescribe more chemotherapy, and it really add less confidence to use oncotype for such patient proportion, whether it's the chemotherapy is related to the ovarian suppression that you have described, or it's part of the direct effect of chemotherapy on the cancer cell. And the question here is how to deal with such, and because in our real practice, does this mean we can, if we think it's an ovarian ablation, does this mean in real practice we can avoid chemotherapy and just intensify endocrine therapy with ovarian suppression? Does this justify this or not? And that's probably the question.
Well, let me tell you about two cases I shared with our fellows this week. These are patients I saw in the past week or two. So one was a 45-year-old woman. She'd had a screening mammogram. She had breast cancer, ER positive, HER2 negative. She had a sentinel lymph node biopsy. She had a single lymph node that was positive, 1 lymph node out of 4. We sent an oncotype score, and the score came back at 12. And because the tumor was a 1 to 2 centimeter cancer with 1 lymph node, I said, I think there's very little benefit for chemotherapy. The oncotype score at 12 is very low. And I recommended that she get ovarian suppression plus endocrine therapy. The second case was a 45-year-old woman as well. She had multifocal breast cancer. She had a 2.5 centimeter cancer in the breast, but then another satellite of 1 centimeter and another satellite of 0.5 centimeter. She had sentinel node surgery and had 3 positive lymph nodes. And then she actually had a completion axillary dissection. There was no more disease in the axilla, but she had 3 positive lymph nodes. We sent her oncotype score because she was interested, and that came back at 19. In that case, I said, you know, I can't prove to myself that I can get everything with the ovarian suppression. This is a higher risk cancer with more nodes, multifocal disease. I recommended chemotherapy to that patient. So those are very similar, but that sort of gives you a framework, I think, for how we're using these tests right now. Lower scores, less disease in the axilla, probably fine to skip chemotherapy. When you begin to get, pushing all those boundaries, I think you can't say that there's absolutely zero role for chemo. And so we will still be using a little bit of chemotherapy in those patients.
Abdullah, can I extend a little bit on this, if you don't mind?
Yeah, go ahead.
Thank you all, really very distinctive talks. Dr. Harad, the problem is now that our pathologists stopped sending after Bonder X data, stopped accepting to send for OncoDX for INGA1. I totally agree with you. I don't think, 48 and 50 are a different cohort of patients. And I don't see why somebody at the age of 49 should have chemotherapy and 50 plus 2 months should not have chemotherapy if they have the same OncoDX. This is really, it's not, I don't want to say much, but after Bonder X, I mean, some people who really believe in black and white, they said, no, premenopausal, less than 50, no need to do it, don't waste money, give them all chemotherapy. So to me, we have been pushed back to the square one where, we were trying very hard over the last 15 years not to give chemotherapy. And this study actually was musical to some of their ears. And they wanted, chemotherapy became more, last week I had to agonize with the patient because I cannot do OncoDX for her. She had only one lymph node and she had 3 centimeter disease. She was crying when I said, I'm sorry, I have to give you chemo based on the recent, recommendations from the hospital. I cannot do OncoDX for you. So how can you help us in that?
So I think we can help in it. Well, first of all, that is the dilemma, and you're exactly right. And actually, I think people have made too much of the premenopausal, postmenopausal thing. The overall study result shows a 1% benefit for chemotherapy. It's trivial. And I totally agree with what you just said. I don't think a 48-year-old is different from a 52-year-old when the oncotype scores are similar. In fact, if you really believe that premenopausal women benefit from chemo, you have to have some explanation that doesn't account for grade, ER status, HER2 status, and oncotype. And I've never heard what that explanation would be, that the tumor is suddenly sensitive to chemo. So national guidelines are going to come forward, at least in the US, which will say that it's okay to do the oncotype test. I don't know if that will be sufficient guidance for international audiences like yours. But I think the real task is to have a conversation with the pathology department and say, we're probably overselling the role of chemotherapy here, and we need to continue to explore genomic signatures or Oncotype DX in particular as a tool. I suspect that if you reach out to the company, they might be interested in working with you on that because they have an interest in using these tests in premenopausal women. You also might want to think about things like Ki-67 and grade, which are used internationally as surrogates for the genomic signatures. So I really appreciate the dilemma, but I don't think the right answer is to simply say all premenopausal women get chemo. We've come too far in the past 25 years to go back to that posture.
Thank you.
The only way you would have a definite answer if you randomize these women to chemotherapy.
Sorry, Athar, we cannot hear you well.
I think the only definite answer we'll have if we randomize these women to chemotherapy versus ovarian suppression with tamoxifen or with AI, and then you will have a definite answer. So we cannot, I don't think we can just ignore the data and go back to our gut clinical feeling, because that will be, I think, also a bias. This is a well-designed randomized study. And what Professor Burstein have said in the 2 cases, the 46-year-old who recommended chemo for oncotype of 19, that's what also the expounder will say, that you give her chemo. And that's what he recommended. So I think it's exactly following the expounder rather than anything else. So
he did not follow.
I believe we have to have more data to just ignore. I think premenopausal versus postmenopausal is a potent factor. It is prognostic and predictive. Seems to be predictive as good as Oncotype DX based on the data. That's how I will interpret the data.
So Athar, no, before you leave, Athar, please. Will you do OncoDX for 49 years of age? And you will not do it for 49, you'll do it for 50?
Nobody said that,
Yeah,
Dr.
I mean,
Ahmed. We are not doing Oncotype by age. We are doing Oncotype now by the nodal status. If somebody is having 1 to 3 positive lymph node and she's premenopausal, I will not do Oncotype based on the responder data, because that tells me that this patient has sufficient risk to receive chemotherapy. And until we have a randomized study where we show that ovarian suppression is as good with tamoxifen or AI, I think that's another opinion you cannot refute. You cannot say, oh no, we should not embark on chemotherapy because it's 49, it's one more year and become 50. No, I don't think it's the age, Dr. Ahmed, alone. It's the age,
I'm talking
it's the nodal status and the oncotype level. These three, you are not making decision based on age alone.
No, the problem, Dr. Adhar, is we are not doing onco. I mean, I'm talking about two similar patients, 1 year apart or 2 years apart, one postmenopausal, one premenopausal, the same nodal situation. One you do onco, the other one we are not allowed to do it now. You don't know it. Onco might be 5, score might be 5. We don't know. But all the Bonder X have really pushed us back to say those patients will benefit from chemotherapy. And the recommendation was don't even do OncoDX. That's what bothers me. If I do onco and it's high, I will give chemo. But if I do onco and it's 5, why should I give chemotherapy? That is really what I'd like us to think about. Is it right not to do onco? That is my question.
Yeah, Dr. Ahmed, I agree with you. I don't think we have right answer for all of this, because this trial really, it answers some question, but really creates more questions. So I don't think we can answer such. And just to keep up with the Q&A, I will just go with the second question, which have to do with the CDK4/6 and where we stand when it comes to a CDK4/6. We do have trial that positive, other was negative. I was wondering about the Monarchy trial, the one that you have shown, and the question, would you consider a CDK4/6 inhibitor for any particular patient? And if yes, which really the risk feature that you will think this patient might benefit the most? That's the first part. The second part, I was wondering about the toxicity that was observed with the Pallas, or the discontinuation rate that was observed with the Pallas. Is probably more than 40 has been have an early discontinuation. I was wondering, is it do we have different toxicity in adjuvant compared to metastatic setting, or is it more kind of strict within the protocol guidelines for adjustment that was seen within such clinical trial environment, and whether this can be revised or not? Because the toxicity we do see with the CDK4/6 is it's manageable, even though they do have neutropenia, but in our real practice, it's not always a reason to discontinue the treatment. So just your comment on that, please.
Thank you. Very, very good, two important questions. To the first one, I would say, in the adjuvant setting, I think the Pallas was sort of strongly negative in a way. Yes, the discontinuation rate was very high. If other studies have shown us otherwise, maybe we rethink the issue. But I think in the adjuvant setting, unless you think, for example, the patient had 16 out of 18 lymph nodes involved, he has high-grade tumors, very large disease, and so on, and you want to think about it, well and good, but not the common garden sort of patients. I think the adjuvant setting is not settled. It's negative so far. Pallas is a phase 3, it's a good study, but it's not proven to be beneficial. I'll come back to the discontinuation rate. The discontinuation rate is very high for no good, it was not really explained. Most of the patients have sort of discontinued because of side effects. So they did not exactly say what sort of side effects. Is it, leukopenia? Is it something else? So I think we need to have more data on both issues. In the neoadjuvant setting, though, I think the story is different. I think we will be using more combination therapy in the higher grade, larger disease in the neoadjuvant setting, but we need to have more proof. We have seen it in the study we have been sharing in. We have complete remission in some cases and really good reduction of tumor size. So that is there, but I think we are still also to wait for more evidence.
Let us take some questions from the audience. This may be for Dr. Murshid, and he's asking about, still we are in the unknown regarding the extended adjuvant. Who is the best candidate for extended adjuvant?
We're always at the unknown in oncology. We're never in the known business. Anyhow, as I said, the benefit, we should weigh actually the benefit versus the harms from any treatment. Those patients with the factors that can predict high risk in these patients, such as stage, nodal stage, the grade, the other bad biological features, Maybe sometimes the age or the menopausal status can play a role, but overall, I think everybody, in my view, is a candidate for the extended adjuvant therapy. And as I said in my final slide, if you remember it very well, that we should take into account the patient preference. We should have very deep discussion with those patients. We should see what affect their quality of life, especially sexual and bone, the desire for other children. It's all these things should be taken in consideration. Finances should be taken in consideration. As I said, if the patient is going to pay for it or not, alhamdulillah, this is not a problem in Saudi Arabia, but it might be a problem somewhere else. And here you can actually use cheaper options, tamoxifen, rather than using AIs if you cannot afford it. This is what I got. Maybe the others can contribute to this question also.
Okay. There is also one question about the role of oncotype in neoadjuvant. Any role for that in the neoadjuvant treatment or no?
If I may hint to the study we have been doing, this is a very good point as well. Oncotype classically is being done on the surgical specimen, but we have been doing it on the TrueCut biopsy in the neoadjuvant setting. And we have, I think, data to suggest that it's as good in a predictive sort of value. And to no chemotherapy versus chemotherapy, as I said, we took 31 as a cutoff. Anything above 30 went for chemo, below 30 went to have neoadjuvant hormonotherapy plus minus CD4. That was the study I was hinting to. Now, if you ask me, people who have high score, will they benefit from? I think this is going to be maybe the second question. Does chemotherapy help patients if they get CD4/6 plus hormonotherapy versus chemo in the neoadjuvant setting? I think personally, I'm eagerly waiting for any data to try and avoid chemotherapy in the neoadjuvant setting if we can, do they really benefit from chemo if you give CD4/6 in the neoadjuvant setting? That would be an important issue as well for the future. Dr. Harold, anything to add? A very important point.
Yeah, we too are intrigued by this idea of using the oncotype to select hormonal therapy versus chemotherapy for neoadjuvant treatment. The dilemma with neoadjuvant endocrine therapy is that, in my experience at least, it rarely converts the patient from needing a mastectomy to a lumpectomy. And so, it's very unusual that we see that dramatic a clinical response, and you probably have to use it for 6 or 12 months to really achieve that kind of response. Many patients don't like to wait that long for surgery. So we actually talk about neoadjuvant endocrine therapy much more than we actually do it, though for many patients, it is a good option if they have larger tumors at baseline.
But you were using hormonotherapy alone, I believe.
We were often, and we have yet to adopt widespread use of the CDK4/6 inhibitors, waiting for maturation of the Monarch E trial in particular.
Can I ask a question, please? Thank you all for the excellent presentation and excellent discussion. My question is to Dr. Harold. First of all, thank you for accepting our invitation.
Honored.
And thank you. My question is, now we start to see BCI or breast cancer index in the NCCN guideline. We don't have this facility yet, we're not using it. In your experience, how beneficial is that in helping in extending tamoxifen to 10 years versus 5 years? Thank you.
That's an excellent question. As I indicated, we're all looking for markers that will help us decide whether there's a best endocrine approach or whether one should get longer duration of therapy than another. Some earlier data for the BCI assay had indicated that in the Atlas trials that were referenced earlier, that perhaps the BCI study could identify patients who were uniquely to benefit from longer durations of treatment. The data I showed here tried to make the point that I think neither the MammaPrint nor the BCI test at this moment predicts benefit for extended versus regular duration of treatment. So I make the decision for extended therapy based on stage mostly. So women who have node-positive breast cancer, I'm more likely to offer extended adjuvant endocrine therapy. And I do not repeat a genomic test to answer that question. One of the interesting things about the Oncotype test is it was developed to optimize the prediction at 10 years. So it's very hard to distinguish the 5-year versus 10-year outcomes with the Oncotype test because it was built to look at the 10-year analysis. So that sort of factors in extended therapy, I guess, if you want to think about it that way.
Okay. Dr. Abdullah, for the sake of the time, if you agree, I think we will finish this session. Thank you for all the speakers. And so we will have break for 10 minutes, and then we will come back for the satellite symposium. Thank you all.
Ma'asalam.
Bye.
Thank you again.
Thank you.
Thank you. Great session. Thank
you
you for inviting me.
Great to have you, and I hope we'll meet in person in future, inshallah.
Indeed, it would be very nice to imagine getting together again soon. You look well. I hope everybody's well.
Thank you very much. Thank you. Take care. Bye.
Dear speakers, I think we have some questions in the Q&A box. So if you have some time, can you please answer them in writing if you have time? Thank you very much for your time.